Okay, you're live now. Just starting the webinar.
Welcome all to this webinar on the macroscopic examination of urological pathology specimens. These webinars have been sponsored by the British Association of Urological Pathologists, the British Association of Gynecological Pathologists, and the Journal of Clinical Pathology. It's part of a series of webinars which have been which included a general as well as from multiple specialities. These webinars were based on a series of papers published in a symposium in the Journal of Clinical Pathology, the March 2024 issue of JCP. These papers are now made open access, so they will be available to view and to read without a subscription. Today's session on the macroscopic examination of urological specimens will be two presentations by myself. I'm Murli Varma. I'm a consultant histopathologist at the University Hospital of Wales in Cardiff, United Kingdom. And my co-presenter will be Professor Sean Williamson from the USA. Unfortunately, Sean was unable to be here. So he has provided a recording of his lecture. So we will use Sean's recording. But fortunately, we have a glittering panel of experts to be involved in this discussion. So these include Professor Michelle Hirsch, Chief GU Pathologist at Brigham and Women's Hospital in Boston, Massachusetts, the USA. Professor Ankush Sangoy from Stanford Healthcare in Stanford, California, again, USA, and Professor Stephen Smith, Director of Genitourinary Pathology, Virginia Commonwealth University, Richmond, Virginia. Professor Pierre Huntan is a very eminent uropathologist and a breast pathologist, so I'm sure familiar to many of you. She is a senior consultant pathologist at Luma Medical Center in Singapore. Dr. Sambit Mohanty is the Director of Surgical and Molecular Pathology at Core Diagnostics in Odisha in India. And Dr. Anne Warren, a very good friend of mine, is an associate lecturer at Cambridge, United Kingdom, and she is also the secretary of the British Association of Urologic Pathologists, which is the main sponsor of this event. So thank you all to the panelists who will be involved in the discussion. Just a couple of points that I need to make before we start. All those who are attending on Zoom, if you have any of your questions, have to go into the Q&A box. Don't put any questions in the chat function, because the Zoom chat function will not be monitored. Those who are viewing this session on YouTube should put their questions into the YouTube chat function. So we will be monitoring the chat function on the YouTube, but not the chat function on Zoom. So let's start then. We are going to start with a presentation on microscopic examination of kidney and testis specimens by Professor Sean Williamson. Professor Williamson is the Director of Genitourinary Pathology at the Cleveland Clinic Foundation. He's Editor-in-Chief of the International Journal of Surgical Pathology. He has contributed widely with numerous publications. He's a contributor of the WHO fascicles in kidney, bladder, and mesenchymal chapters, the AF5P fascicle, as well as the Atlas of GU Pathology. So I will now let me stop sharing here, and Preeti will now play the recording of Sean's lecture.
Hi, thanks for having me. I apologize. I had a conflict come up, and so I had to record my presentation in advance. I apologize for that. But my name is Sean Williamson. I'm from the Cleveland Clinic, and I'll be talking about the gross examination aspects of kidney and testicular tumors. I think kidney cancer staging can be challenging because the invasion of kidney cancer into structures is sort of different than what you expect of the prototypical cancer. Prototypical cancer would have desmoplastic reaction and an infiltrative growth pattern. But with kidney cancer, the tumors are mostly spherical with sort of subtle outpouchings into vein branches or the renal sinus tissue. And so I think this can be somewhat counterintuitive for the pathologist who is not specifically interested in kidney tumors or GU pathology. And hopefully I'll be able to demonstrate in at least a couple of studies as we go along today that I think that there is an importance for prognosis if these subtle invasion goes undetected. Largely, renal cancer management does not include adjuvant therapy, even for high-risk tumors that have high stage, such as vascular invasion at nephrectomy, but there are clinical trials and there is an option for adjuvant therapy for higher risk tumors. So there may be some importance to recognizing this for us as pathologists. I have a few photos throughout the presentation from the IAP conference a few years ago in the Dead Sea area near Amman, Jordan. I gave a part of this presentation related to kidney tumors there, and so I have a few images from that meeting. This is the Dead Sea area where the conference was held. So for handling of renal cancer specimens, one issue that may come up is how to open a radical nephrectomy specimen. In the ISUP consensus several years ago on handling of renal tumor specimens, there was a strong agreement that specimens should be opened through the long axis of the kidney, but there are several options, either cutting through the renal pelvis, cutting through the main renal vein, or sort of choosing the midpoint of the tumor from where you can see it bulging off of the contour of the kidney and making a cut that sort of angles toward the hilum. I think all of these options are acceptable. Basically, the goal should be to highlight the interface of the kidney tumor to the renal sinus, which is the most relevant area for staging. I think with inking, it's reasonable to be selective, since if a kidney tumor actually does involve the soft tissue margin of a radical nephrectomy specimen, it usually would be grossly apparent that the tumor is infiltrating the soft tissue and visible on the surface. So I don't think you have to necessarily waste a whole gallon of ink covering the entire fat of a kidney tumor specimen necessarily. It can be selective if there are areas that would be more suspicious for adherence to the tumor. In a partial nephrectomy specimen, often I see specimens that look like this. You can see the kind of golden yellow tumor there. In these areas highlighted by the red line, sort of laterally, there's often more renal parenchyma margin. But then just under the tumor in this area highlighted by the yellow is where the tumor is more likely to come close to the surgical margin and perhaps abut the margin. I'm usually pretty generous with interpretation of margins in this area. If the tumor is coming very close, but there's even a wisp of connective tissue around the tumor, I usually would interpret it as a negative margin. And if it really does appear that the tumor is abutting the margin, I often give kind of a descriptive that the tumor is abutting, is abutting the margin, but does not appear transected, since often the surgeons can appreciate that there's nothing underneath once they've removed the tumor. Maybe they're seeing renal sinus tissue with fat or the collecting system, and so they can see that there's no more gross tumor. And so I'm a bit cautious in my wording not to imply that the tumor has been transected, but rather it may be abutting the margin. And I'll show some examples in a minute of how sometimes vein involvement at the margin can be tricky. The green line here highlights the perinephric fat margin, and I would worry the least about this margin in a partial nephrectomy specimen. One, because typically the surgeons will sort of peel back the adipose tissue to gain a view of the tumor. And so this partly is often artifactual in that there is additional fat that they have removed. And then secondly, as I mentioned, if the tumor is going to invade the perinephric fat, usually you can make out that grossly it is adherent to the fat and difficult to sort of peel away the fat. And so you would have a higher suspicion if you knew that it seemed like the tumor was involving the fat. So here's the perinephric surface of a partial nephrectomy specimen. Again, you can see most of the fat has been sort of peeled away here, and we can see the smooth surface of the kidney capsule. And there are some little bits of fat that are sort of clinging onto there. But most likely the surgeon has dissected a substantial amount of fat off of the tumor to get this visualization. Sometimes we'll receive that fragment of fat as a separate fragment within the specimen jar, or sometimes we'll receive it as an entirely separate specimen altogether, in which case my sampling is generally pretty limited. I would just cut through it and see if there's anything other than what looks like normal fat, and if not, I don't think you have to submit numerous sections, maybe one or two at most. On the other hand, the parenchymal surface of the partial nephrectomy specimen may be more revealing. Here in this specimen, we can see some yellow fat where the renal sinus is starting to appear, but there are these nodules highlighted by the red circles where I think we can start to see that the tumor is bulging toward the margin, and those would be the areas of most interest for a potential positive margin. However, I think you can even make out here there might even be sort of a thin membrane over these areas of yellow tumor. It doesn't look like the tumor has been transected. This may be early extension into into vessels where there's just a very small thrombus that's not yet fully into the vein. Dr. Stephen Bonsub has done some impressive work on staging of kidney cancers, and I just thought this was an interesting article if you have interest in learning about some of the anatomic aspects of kidney specimens, how the veins, the renal sinus, the veins exist, and all of that. If you scan the QR code, it will take you to that article if you want to check it out. And then secondly, I've already alluded to the ISUP consensus on handling and staging of renal cell carcinoma, which is now over 10 years old, but I think essentially all the principles remain basically the same in current practice. The only major change to the staging, I think, since then, well, we'll talk about a couple of minor changes, but the one major one is that renal pelvis involvement has been added as a way to reach PT3A stage, which was not addressed in prior staging. And this is again from the city of Petra in Jordan, which we visited while during that IEP meeting a few years ago, where I spoke about kidney tumors. So the staging system from the AJCC and UICC has changed a little bit from the previous edition to the most recent one, in that involvement of renal vein or branches no longer is required to be grossly identified. So that word grossly that's highlighted there was removed in the latest edition of the staging system. And it's no longer required that segmental branches of the renal vein have muscle to be identified as a vein invasion. And again, this partly at least comes from work by Stephen Bonsub, who found that you can manually dissect renal vein branches into the kidney where they're still grossly appreciable, but microscopically the wall may not contain muscle, or it may have eccentric muscle where some areas have muscle and other areas don't. So those two aspects have been removed, and essentially if you can identify a renal vein branch invasion, even microscopically, it is considered T3A stage. And then, as I mentioned, renal pelvis involvement was added as another route to reach the T3A stage in the latest staging system. The higher levels of stage have not really changed much, but depend on extension of the tumor into the vena cava, and how far exactly does it extend into the vena cava, or does it involve the wall. But the main determinator of renal tumor stage, at least for the smaller sizes, is the tumor size. And so the main cutoffs are 4, 7, and 10 centimeters. So I always try to make sure I have a good measurement whenever the tumor is lurking around one of these size cutoffs. You know, if you're right around 4 centimeters, I try to make sure I can check all 3 dimensions. Sometimes it may be relevant to correlate with the imaging to see if the gross measurements that you're getting are similar to the clinical measurements. There is some data suggesting that there may be slight shrinkage of the tumor from what is identified radiographically to the fresh unfixed specimen to the formalin fixed specimen. The size may be slightly decreasing across all of those measurements. But the exact amount of that difference in measurement has varied a bit between studies, and in general, it's not huge. But it is reasonable to correlate with the imaging to see if the tumor is right around one of these size cutoffs, especially if you think the largest dimension of the tumor might be the plane perpendicular to the plane that you sectioned it in, which is harder to sort of reapproximate and get the accurate measurement. This picture is actually a papillary renal cell carcinoma. So you can see it's rather large from the scale bar there, but doesn't invade any structures, which is more common in papillary renal cell carcinoma than a clear cell renal cell carcinoma. And as we'll talk about in a minute, it's quite rare for clear cell to reach a large size without invading any structures. So we mentioned the renal sinus. What exactly is that? The renal sinus is this compartment of fat around the hilum that contains the blood vessels and the renal pelvis. And again, thanks to a lot of work by Steve Bonsub, it's been shown that this is the main invasive pathway for renal cell carcinomas. They're more likely to invade this way than they are to invade, for example, the perinephric fat. And one of the major works that he did was personally examining a series of over 100 clear cell renal cell carcinomas he performed a dissection himself on this series of tumors, and he found that as the size increases, the likelihood that the tumor invades the renal sinus goes up dramatically, to the point where, if you see this red line here, as we go over 4 centimeters, it's more likely than not that the tumor invades the renal sinus. And as you go up to 7 centimeters, it's approaching 100% that almost all tumors invade the renal sinus. So how to use this in practice, I will take additional sections from the interface of the tumor to the renal sinus when I start to see a tumor that's over 4 or 5 centimeters. Submitting the entire interface may be excessive if that's going to take numerous blocks, but I at least would try to take 2 or 3 specific blocks of the tumor interface to the renal sinus to try to capture that invasion in a larger tumor. And is there proof that it's important? I always love to refer to this study, which is really an amazing study done at the Mayo Clinic. I think almost no one could recreate this study because they had saved their gross specimens from renal tumors for multiple years. So at least in the United States, we have a requirement to keep a gross specimen for, I think, 2 weeks after the report has been released. But at the Mayo Clinic, at least during the time of this study, they were saving specimens much, much longer than that. And so there were patients who had actually died of renal cell carcinoma that was allegedly stage PT1. And they went back, and there were actually 33 of these specimens that were still saved. They still had the gross specimen, and they re-examined it and found that there was a fairly high rate of underdiagnosed renal sinus or small vein invasion. So 42% undiagnosed renal sinus invasion, 58% small vein invasion. And if you combine them, so the tumor having either one of those, there was about 2/3 that had one of those missed. And even more impressively, they did a control group where they looked at T1 patients who did not have death from renal cell carcinoma. And there was some undiagnosed invasion in those patients, 21%, but that was significantly different than the patients who had died. So I think, to me, I always quote this study as evidence that there is prognostic importance to recognizing probably even subtle renal sinus or vein invasion. So what exactly is renal sinus or vein invasion? I think it can include either direct soft tissue involvement or involvement of the vascular spaces in the renal sinus, which could include vein invasion. And the way to report this, I think, is a little bit up to interpretation. When a tumor involves the renal vein in the renal sinus, do you say that it's renal sinus invasion or renal vein invasion or both? I think that's a little bit up to the individual how to handle that. But the ISUP consensus several years ago agreed that tumor, even microscopically within the renal sinus, would also count as a renal sinus invasion. So in terms of larger vein involvement, here's an example of a large renal tumor with this sort of sausage-shaped nodule extending into the main renal vein branch at the hilum, extending down toward the 3 centimeter mark of the ruler here. So that would be kind of a classic example of a large vein branch involvement that would likely even be recognizable as in the main vein outside of the kidney, perhaps. I often become highly suspicious for vein invasion when you have a tumor that is bilobed or multinodular. So it's not totally obvious to me that either one of these 2 nodules is a vein. If so, it's completely filled up. But the fact that there are 2 nodules kind of bilobed, or sometimes I refer to it as the snowman sign, where it looks like a snowman with a smaller nodule on top of a larger nodule, and I become very suspicious that this represents vein invasion when you see that pattern. Another feature that I sometimes look for at the gross level is a clefting around the areas that maybe represent vascular invasion. So here we have this area highlighted in red, and if I take away the red outline, you could sort of see that there's a cleft around that area. Also, if you kind of flex the specimen, that might accentuate the cleft, and you can further support your impression that that's within a vein. Actually, just above the red highlighted area, you can also see multiple nodules. So even those areas may represent vein invasion. There's sort of a elongated nodule just above the red line, which to me probably also represents vein invasion. This is an example which I thought was underdiagnosed as organ confined. And again, you can see sort of the snowman sign, or in this case would be an upside down snowman with a larger nodule and then a smaller nodule beneath it on the gross exam. I think the pathologist who saw this case was interpreting this as multiple tumor nodules. And in fairness, there's not much of a lumen around any of these structures that you can see on the right-hand side. But to me, this presence of multiple nodules like that strongly implies that one of them is within a vein. And at least the bottom one, there's a bit of a cleft around it, suggesting that that is possibly in a vein branch. I mentioned earlier, sometimes you can even see nodules extending into vein branches in partial nephrectomy specimens. I think the assumption would be to assume that in a partial nephrectomy specimen that the tumor is going to be organ confined because it's small, but it is possible to have vein or sinus involvement in a partial nephrectomy specimen. And in this one, I think we have a small kind of mushroom-like outpouching of tumor into the renal vein branch at the margin. And you can see in this specimen, it's smooth and round. So I doubt that this was actually transected. I think that probably the surgeon entered the vein, opened it up, and this little polyp of tumor came out. But I doubt that there is necessarily residual transected tumor. So I would often give a descriptive diagnosis for something like this, that there is a nodule of tumor in the vein branch at the margin. However, it does not appear transected or something like that, to convey that I don't think that there is necessarily residual tumor, at least based on the gross appearance. Here's an example of the cut surface. It's a little bit messy, but you can see that there is the main hemorrhagic nodule, and then there are these finger-like outpouchings going away from the nodule and abutting the margin. This is a different one, but illustrates it a bit better at the microscopic level. You can see the main tumor, and then this finger-like outpouching that's extending away from the tumor to abut the margin. And I know we're not really talking about microscopy too much here today, but just an illustration of the microscopic correlate of what we just saw, that there are these nodules that are a little bit distanced away from the tumor. And here a bit of a cleft around it and a small amount of muscle in the wall, sort of demonstrating that this is a small vein branch, even though it would be subtle. And again, we're not really focusing on microscopy, but this is just an example to illustrate that although the gross examination on this patient did not recognize vein involvement grossly, there is this separate nodule within a vein lumen recognized microscopically. So again, that gross requirement was removed from the current staging system. This is an example that I thought was reasonable for perinephric fat invasion, and actually the tumor was a chromophobe renal cell carcinoma. Here we can see this outlined in red, kind of the main part of the tumor, and then this area with the red arrow, there are a few nodules that are kind of at the edge of the tumor there. And we look at a different slice grossly. Again, there's the tumor, this area of some nodules that seem to be sort of outside that round contour of the tumor, and then even more few nodules that are outside there, kind of satellite floating in the fat. And again, the microscopic correlate here was that there were small nodules of chromophobe renal cell carcinoma out in the fat. So I interpreted that as perinephric fat involvement. It is possible that some of these represent lymphovascular involvement, but hard to say for sure since there's not much of a cleft around them. So I interpreted this as perinephric fat invasion, just to sort of cover that. Another form of vascular involvement in renal cell carcinoma is so-called retrograde venous invasion. And the hypothesis here is that when a tumor involves the main renal vein branch, sometimes nodules of tumor begin to grow backwards or retrograde into smaller renal vein branches, creating multiple nodules. So here in the red, I think, is kind of where the original primary tumor probably existed. And then we can see this yellow outlined area where the tumor starts to extend away from that into a large vein, the main renal vein branch. In green, the other side is probably some perinephric involvement, but then all of these nodules at the black arrows to me represent retrograde venous invasion, where the tumor has grown into the main vein and it's looking for additional places to spread, and it's forming multiple nodules throughout the renal parenchyma. Now, this isn't necessarily different for staging purposes than T3, but I would be aware of it and interpret this as a single tumor with a high stage rather than multiple tumors. And so, again, Dr. Bonsib's group did the first major study on retrograde venous invasion. And a study that I did a few years ago with a trainee who later became our GU fellow. We looked at renal cell carcinomas with specific emphasis on renal vein and retrograde venous invasion. And I just wanted to highlight here that these were all tumors. We specifically selected tumors that I myself reported to kind of ensure that the staging was done in a similar way for all of them. And we found that it was very rare to have multiple clear cell renal cell carcinomas. If the patient has von Hippel-Lindau disease, that's possible. But in the sporadic setting, it's very uncommon to have multiple clear cell renal cell carcinomas. The tumors that were multifocal usually had a different histology, such as papillary renal cell carcinoma or clear cell papillary renal cell tumor. And so there was only a single one which seemed to be possibly multiple clear cell RCCs, although even that one is debatable because the main tumor was of high stage and the second tumor was sort of discontinuous from it, but remained suspicious that that may have actually also been some kind of intrarenal metastasis or something like that. So here's just a diagram from our paper showing where the letter T is. That's where I think that the primary tumor originally was. The letter V shows the main renal vein involvement with a large tumor thrombus. The white arrow is a small nodule within the renal parenchyma, likely representing retrograde venous invasion. And then circled in the white circle, I think it becomes difficult to figure out how much of that is intravascular or how much of it is the original primary tumor. Dr. Bonsib in his work has suggested that you do not include the intravascular component in the measurement of the tumor. So you would just measure that area labeled as T for the measurement of the primary tumor. Although if you've captured the vascular invasion, then you would know that this tumor is of high stage. And so the measurement would be less critical. Again, won't focus too much on the microscopic today, but again, here's the correlate of that same slide with that same specimen with the microscopic T for the primary tumor, B for venous invasion, and then at the arrow you can see it's starting to spread backwards into the renal parenchyma, making those separate nodules. In terms of assessing the renal vein margin of a nephrectomy specimen, sometimes you'll have tumor thrombus in the lumen of the vein at the margin. And the way I would approach this is if the tumor is completely freely mobile within the lumen at the margin, if you can trim that vein wall around and the tumor does not stick to it anywhere, then I would consider that margin to be negative. And you can cut it off and place it in a cassette showing lack of adherence of the tumor to the wall and interpret the vein margin as negative. But in this one, you can see there's a cleft around 2/3 or 3/4 of the tumor thrombus, but at the top it's sort of stuck to the vein wall. And actually I sort of flexed this specimen with my hand to show that it couldn't, that it wouldn't separate from the wall at the top. And so I would consider that a positive margin if the tumor is truly invading the wall at the margin. So if you have something like this where there's clear space all the way around the vein thrombus in your margin section, I would consider it negative. For other sampling for the kidney, looking at the adrenal gland, it's important to check whether the involvement of the adrenal gland is discontinuous, which would be considered a metastasis, or contiguous, which would be considered a T4 primary tumor. And then it's also relevant to sample some areas away from the kidney, away from the tumor for evaluation of medical renal disease. If you're interested in more of the microscopic challenges, we published a paper a few years ago looking at challenging staging in cell carcinoma, which you can find here. So for the kidney, some key points, I would be suspicious of large tumors that are greater than 4 to 5 centimeters. And be suspicious of any deviation from a spherical shape, either an elongated outpouching or the so-called snowman appearance. And consider the possibility when you have multiple tumors that they may actually be within vein. So if you have multiple tumors of the same histology, especially clear cell type, consider the possibility that some of the smaller ones are vein involvement. And then moving on to the second part, testis. When doing the gross examination of a testicular tumor, I usually consider the first step to be taking the spermatic cord margin. And the significance of that is that testicular tumors, especially germ cell tumors, are very friable. And so it's very easy for tumor cells to be spread all over the place, including within lymphovascular spaces. And so if you take that cord margin before you've even messed with the primary tumor, then there is less likelihood that the cord margin will have contamination of cut tumor cells all over it. Secondly, you could also take the additional sections of the cord if you are doing so at the same time. That way, again, there's less likelihood of those being contaminated with cells that are spread from cutting of the tumor itself. And then finally, opening the tumor completely and getting a good amount of fixation before further processing is often a good technique. And again, we're not focusing on the microscopy, but just to show that when that you can have spreading of tumor cells artifactually all over the surfaces of the specimen. Sometimes people refer to it as buttering, where there are tumor cells kind of spread all over. The reedy testis is the network of tubules at the hilum that connects the seminiferous tubules to the efferent ducts and then to the epididymis. And involvement of the reedy testis doesn't necessarily affect the tumor stage, but some authors may consider it a predictor of metastasis. It is possible that involvement of the reedy testis is sort of a surrogate for a larger tumor. Some have suggested it's associated with higher risk of relapse in clinical stage 1 seminoma. And so we try to report the involvement of the reedy testis, despite that it's not a staging parameter in and of itself. So how to capture the reedy testis when you're taking your samples. I would often just, you may not always see the reedy testis grossly, so I would often just take samples that include the interface to the hilum and the epididymis, and usually you'll happen upon the reedy testis by doing that. That's probably easier than trying to see it with the naked eye. Often the staging of testicular tumors is relatively simple, and especially in the older staging system, the main factor was lymphovascular invasion or not for T1 versus T2. Involvement of the scrotal wall I would consider to be very rare. I've seen perhaps once or twice, so I would be very hesitant to diagnose scrotal invasion unless the surgeon has given you an adherent wall of skin, basically. Here's an example of a testicular tumor where they've actually taken a sort of hydrocele sac around the tumor with it. You can see this membrane of the tunica around the testis. But even so, at the arrow there, the contour of the tumor and the tunica vaginalis is very smooth. And so it's quite rare in my experience for tumor to invade the tunica vaginalis as a route for PT2 stage. So to me, I would look for a tumor that's basically eroding onto the mesothelial line surface of the testis to consider it T2 on those grounds. And most of the time it doesn't. The situation of vascular invasion within the spermatic cord was, it has been challenging over the years. In the previous AJCC staging and UICC staging, it was not exactly specified what to do with vascular invasion within the spermatic cord. I mean, certainly I would consider that T2 for vascular invasion, but if the tumor begins to break out of the vessel into the soft tissue, does that become T3 cord invasion, or should we consider it something else? In the 2018 AJCC staging system, this was changed to PM1 or metastatic. And that has sort of perplexed me because intuitively, I would think that this is maybe like tumor in transit to the regional lymph nodes. Maybe it's the same as invasion of the spermatic cord, but M1 is basically equivalent to lung metastases or distant organ metastases. And so I'm not sure that involvement of the spermatic cord as a discontinuous nodule is necessarily as bad as that. I'm suspecting that the logic used there was this is metastasis to a site other than regional lymph nodes, and therefore it was considered M1. But interestingly, if you look in the US National Comprehensive Cancer Network guidelines, they specifically state for clinical purposes, not to treat the patient as M1, because adding an M1 would bump the patient to clinical stage 3 immediately. But if by imaging they have, for example, no disease outside of the testis, then the NCCN guidelines recommend that still that can be managed as a clinical stage 1 tumor. So it's interesting that there's this discrepancy between the pathologic staging and the way clinicians would treat it. So I personally try to dodge around this issue if I encounter it and put a note saying that there's this discontinuous nodule, however, and it's debatable how that should be handled in practice. So here's just an orchiectomy specimen to kind of illustrate that. If you have a nodule there in the spermatic cord and your section that's before it doesn't show any tumor, then that would be a discontinuous nodule. And we would get into the situation of having to decide how to handle that. Involvement of the hilum and epididymis has been added as another route of PT2 stage in the latest staging system. And just to highlight a couple of studies, this is from the Calgary group, Asli Yilmaz and colleagues, showing that there is an association of testicular hilum involvement with advanced clinical stage presentation. And some more data from their group. And so, as I mentioned, this has been added as T2 in the latest staging system. In the past, it was testis and epididymis was still considered T1, but now in the latest staging system, hilar soft tissue or epididymis invasion is considered also T2. And in the past, you may have wondered, well, if a tumor has invaded the hilar soft tissue or the epididymis, there's probably a high likelihood that it has vascular invasion somewhere in there. And so this sort of locks that in a bit more rigidly, that the tumor is definitely T2 if it invades the hilar soft tissue. And then T1 is subdivided for seminoma only based on size. I often see people using the T1A and T1B staging for non-seminomatous germ cell tumors, but really T1A and T1B based on size is only for seminoma. So if you have a T1 tumor smaller than 3 centimeters, you could just call it T1 for a non-seminomatous tumor. The other aspect of testicular germ cell tumor handling is retroperitoneal lymph node dissection, where metastases are resected. And usually this is done separately from the resection of the primary tumor. In general, there's kind of 2 big factors that contribute to the nodal stage, and that is how many nodes are positive and what is the size of the greatest mass. And I think overall this comes from clinical data, just kind of assessing the bulk of disease. How much of a bulk of disease is there? The more bulk of disease, the worse the prognosis. And so at the bottom there shows the number of nodes and the size of the greatest mass that contributes to the staging. Some factors that we try to report are the amount of necrosis and what components of tumor are present. The vast majority of these specimens will contain either pure necrosis or teratoma. Those 2 things will account for almost all of the retroperitoneal lymph node dissection specimens, assuming that we're post-chemotherapy. Rarely retroperitoneal lymph node dissection will be used as a primary treatment without chemotherapy, but in our practice, almost all of these are post-chemotherapy, and you'll see either necrosis or teratoma. And so with extensive necrosis, I often don't waste a ton of time sampling the necrosis looking for viable tumor. It seems, at least in my experience, to be pretty low yield. And so we would just sample some areas at the edge of the necrosis interfacing with viable tissue. And if you don't see any viable tumor submitted on several blocks, we don't necessarily go back or anything like that. I think it's pretty low yield to find unexpected viable tumor. And so we would just take a few samples at the edge of the necrosis looking for anything. And if it's not there, then we don't sort of aggressively chase viable tumor when there's no reason to suspect it. If the serum tumor markers have not decreased, that may be a reason to look more carefully for viable tumor. But often they will just resect any residual mass that remains after chemotherapy for either teratoma or necrosis. When I trained at Indiana University, this was a high volume testicular cancer center. And so we had a bit of a template like this explaining how much, what was the viable tumor and how much of it was viable and what was the size, et cetera. The College of American Pathologists now has a a synoptic report for retroperitoneal lymph node dissection. But again, the overall stage comes from the kind of the bulk of disease. So are there multiple nodes or are they large? In this case, we have 5-centimeter tumor, which would put it into the N3 stage. However, it's only teratoma, which is considered favorable clinically. It's important to remember that this applies only to the regional lymph nodes. So the regional lymph nodes are basically the ones around the aorta and the vena cava. So they'll have names like interaortocaval, that is between the aorta and vena cava, paracaval or paraaortic, although I have there in quotation marks. Sometimes you'll get funny names written down by whoever is filling out the request forms. I've seen them written as intra-aortic. I doubt that they were actually within the aorta. They probably meant to say para-aortic or something like that, or intra-aortocaval. But sometimes you'll get funny words written down. But usually this would be in and around the area adjacent to the aorta and vena cava, would be a regional lymph node. If you have another site like in the mediastinum or elsewhere, that is considered a non-regional lymph node and therefore a distant metastasis. And remember that since the testes originate in the abdomen and descend into the scrotum, the area around the aorta and cava is their primary landing site, not inguinal or pelvic, as you might think of intuitively. So when in doubt, it's always good to look at the synoptic reporting elements and see what you need to track for cancer reporting. That's always a good place to look. And I use this picture as an illustration. These are my two kids, and when they were very little, they looked very similar. So you're checking the template of what a Williamson baby is supposed to look like. They were following the template and looking the way that they should. But this is them a little bit older, and you can see there are some differences between them as they got older. But at any rate, you can always check the synoptic reporting requirements when you're doing the gross examination of a specimen and see what you need to be looking for. And so thank you again, and I apologize that I was not able to present live in person. I hope this will be helpful, and I hope that the expert panel will have some good discussion. Thank you.
Brilliant. I think you'll all agree that that was an excellent presentation about the macroscopy, and some brilliant photographs. The macro photographs was absolutely stunning. Okay, so what we'll do now is there are a few questions in the Q&A, and if you have any more questions, put them into the Q&A. So we'll deal with the questions in the Q&A, and then we can talk among ourselves if there are other points that the panel would like to discuss. So let's start with the questions in the Q&A. The first one I have here is, does pushing capsulated bud in sinus fat classify for sinus invasion? So I guess macroscopically, if you got something that is like pushing capsulated, you definitely want to block it to examine it microscopically. So this is now a microscopic problem that so essentially the question here is, do you need cellular fat infiltration to diagnose sinus invasion, or is it sufficient for it to be bulging into the sinus? Do you all want to take it? I think my own personal, I think I would require sinus invasion. I would require fat invasion. So I would require almost cellular fat invasion rather than if something is just bulging into the fat. What do you all do?
So I think sometimes it really depends if you can see or in many ways try to reconstruct the three-dimensional growth pattern of the tumor. If it's very close or connected to tumor from the main tumor mass and bulging towards the fat and is encapsulated, then I don't call it. I think the harder issue is when you have something distant or slightly away, maybe it's 1 centimeter, 2 centimeters away from the main mass, but it's completely encapsulated. And I think the things Dr. Williamson talked about is first and foremost, try to decide if you think you're in a vascular space further away from the tumor. If you don't believe you're in a vascular space and you are in the fat and you are completely distinct component from the main tumor mass, then I will describe it and usually consider it PT3A. But if it's close or connecting And occasionally, if I'm unsure, I'll just describe it as bulging, but no direct fat invasion. So I think the proximity to the main mass or the connection to the main mass makes a difference.
I agree, Michelle. I think yes. So I think the situation where I was talking about, yes, when it's in proximity and it's in continuity, and it's whether the tumor is just bulging out into the sinus. I agree with you that if it's entirely discontinuous, it's likely to represent sinus invasion.
Yeah, the fundamental challenge is that the interface between the renal parenchyma and sinus fat doesn't have that nice, juicy, smooth muscle capsule that we see at the periphery. You know, if we're talking about radial perinephric fat involvement, and that makes it challenging. And there's nothing like, I always tell my trainees and pathologist assistants, there's nothing like snapping a picture. For us, this is annotated online, and you can even put cassette B from area indicated on photos. So if I'm not there at the time of the prosection.
The only good thing, I mean, this is, as you say, extremely difficult, but the only positive from our point of view at present is because they don't use adjuvant therapy, it only changes their follow-up protocol. So the clinical implication of this, it's not like something like vascular invasion in the testis, where that would lead to a BEP chemotherapy to a relatively young patient. So this is not as critical as that. But yes, we definitely need to make an effort.
So I'm not sure about all the institutions, but at the Dana-Farber and Brigham and Women's Hospital now, there are clinical trials for PT3A kidney cancer. So I agree, standard of care is if you are negative margins confined to the kidney and surrounding tissues of the kidney, meaning not metastatic, and so your T3 negative margins, there would be just CT follow-up, except for clinical trials now, which have opened up eligibility.
Yeah. So if you're in an academic institution where they're doing a clinical trial, that might be valid for the clinical trial. But if you're in normal clinical, in routine surgical pathology practice, it's very unlikely that it's going to change anything other than And actually, if you look at their protocols, the follow-up protocols, there's very little difference between it's a question of doing one extra ultrasound or one extra CT scan. So it's not a huge difference in the management. So again, that doesn't mean that you make no effort to diagnose any of this. It means that it's not absolutely critical. And in some cases, it's entirely reasonable to say, I'm not sure. And in which case, the TNM rules would be to allocate the lower stage and then to give the possibility. Okay, which section is important to take in a renal grossing if you have to select one among the renal sinus fat and the renal vascular invasion, both of which would be T3A?
So I can take that, sort of chime in, I guess, and similar to I don't know about the margin. I mean, the margin is usually a gross thing, like kind of what Dr. Williamson sort of alluded to, but kind of alluding to back the other case with the vascular. I don't make a huge deal if it's vascular versus the sinus fat versus vascular. They kind of go hand in hand. They're usually cousins, ugly cousins, so to speak. They're usually, if you see one, you often see the other. But I kind of use in the testis, in the kidney, similar to what we do in the prostate, sort of EPE. I do see a bulge in the sinus fat, even though it's not actually kissing the fat, I actually will call it. So for me, I'm very aggressive with sinus invasion, particularly for clear cell. So that's the other thing, is we haven't talked about tumor types. If it's chromophobe or other things, it can well known to have a pushing pattern. But if it's clear cell, I'm a little bit more aggressive in the rendering of PT3A. And then the other thing, especially that size cutoff. When the trainee brings me a case and if I haven't, big kidney tumor and I have not found PT3A, my first question, and it's clear cell, is how big is it? Actually, before I even start, I say, because if it's under 7, and I'm willing to probably let it go, is probably not PT3A. But if it's more than 7, they know that we're going to be going back to the bucket later that afternoon, because I'm a big believer in that Boston study. Is if you go back, in enough greater than 7 centimeters, that cutoff is key. You will find it. You look hard enough, you almost undoubtedly will. I can count in my hands the number of times I've had. Usually it's a regression or a super low grade thing that has a pushing. I rarely do PT2B.
The interesting one is, now let me be a devil's advocate and go the other way around. So if we are saying that practically all patients who have more than 7 centimeters will have sinus invasion, then the other way of looking at this would be, instead of taking a lot of sections for that, we should treat patients with, say, more than 7 centimeter, like T3A. You put them in the same risk stratification
yeah,
as
that's a good
T3A.
point. Yeah, not necessarily.
So
Like I said,
which would
it
be,
happens. It does happen. Like I said, there are some,
but
low grade,
correct, but
regressed.
Correct. But Ankur, the argument here is all of this is about risk stratification and probability. It's not absolute, isn't it? We're looking at, so I think this is something, I'm not a renal expert, okay? So this is something for Michelle and all the renal experts to consider. Maybe, to put these patients into a higher risk category, if it's more than 7 centimeter, saying that they are very likely to have vascular, sinus invasion, and put them in the same risk group. As a group, individual patients may be variable, but as a group, they're more likely to be like equal to that. Michelle, would you buy that argument?
Yeah, so I think it's not so black and white only, and exactly what Dr. Sangoy said is it's really dependent on the subtype of the kidney tumor. So certainly chromophobe, we know, pulls the capsule without invading it much, much more frequently. You can have very, very large 10, 12 centimeter chromophobes that don't necessarily invade. So if you did that kind of stratification, it would have to include subtype as well as size of the tumor. So I think that complicates it. I know, we have a study on small renal masses, and a very large significant of small renal masses defined by 4 centimeters or smaller can have extension of multiple subtypes into or high sinus fat. So size isn't the only factor, but I think with clear cells in a nomogram kind of way, more than a staging way, which is usually across the board for the tumor type, would make more sense. But
yes,
it is a way to think about it clinically, for sure.
Clinically, I think, because the point I'm making here is because, for us to take a lot of sections from a small tumor, the sinus interface is usually a limited number of sections. The problem comes when you get a large tumor. And as you all pointed out, and in most of these cases, if you go and search hard enough, you're going to find sinus invasion. So the other way for us to say, yes, most of these will have sinus invasion. So let's put them as sinus invasion. I agree with you if we're talking about the clear cell ones, because that's the one.
I think the caveat for that is the grossing, and which is, of course, the topic of discussion, is people are often taught about taking a kidney and bivalving it into 2 pieces. And then they look at just those 2 pieces for the invasion. I would argue that first bivalve, but then take 2 or 3 more parallel sections to the bivalve, the central piece, because often I see trainees and PAs will just stop, or whoever's doing it, with that one section and take all their sections from there. But it could be that the tumor is off center. And so if you bivalve it and then take another parallel and another parallel, you might actually find a best section in one of those lateral, for lack of a better word, slices. Parallel, like bread loafing, all the way through. Absolutely. And I think that is a really way to approach before you take your cross sections or your to look at more of the tumor.
That's right. So again, it comes back to the same thing. Is with macroscopy, it's all about being meticulous, taking fix the specimen properly. You can't take thin slices of a specimen unless it's properly fixed. There is no urgency with these resection specimens. If the resection specimen is delayed by a couple of days, it's not going to change anything from the patient's management. These patients are all going to get followed up. So make sure you fix it properly, take thin slices, examine. The macroscopic careful examination is as important as a microscopic evaluation. Good. Let's move to the next one. With tumor bulging into the sinus or even into a perinephric fat, do you sample extensively to show invasion? Sample all the sinus fat with tumor bulging into it. I suspect most of us would. If you're seeing things that are bulging into it, you certainly would want to sample those areas, unless you have, once you've demonstrated it, that's clearly, then you go. If you don't sample all of it and you don't find it, you would have to go back and put the other areas through. Would that be what the others would do?
Yeah. Really, one thing that was, Dr. Williamson sort of addressed is the topic of pelvic helicele invasion. It's kind of a topic I'm particularly interested in. I see Sean grading. Stephen grading there. But so we did it, and some of you were on that USCAP abstract looking at the inter-observer reproducibility among GU people for pelvic helicele invasion. What that means for the folks that are, may not see these specimens that often. You bivalve the kidney and you look at it. It looks like a urothelial carcinoma, tumor sort of polypoid thing, pooching into the renal pelvis. 2 staging systems ago, that did not upstage, and in the most recent last two, all of a sudden it became PT3A. But there's really no rules or no explanation as to how you get to pelvic calyceal invasion. Is it a gross? Is it a microscopic? Does it actually have to push into the renal pelvis? Does it actually have to breach the urothelial mucosa? In this USCAP abstract, I said hopefully it is presented and accepted. But we have some data showing, like I said, may or may not be true, but how people do. But at least for me, I tend to. I mean, usually if I need to see it actually pooching into the renal pelvis to call PT3A for pelvic calyceal, and more importantly, probably eroding through the mucosal layer, not just sort of indenting it. Almost the cases that had the eroding, if there's eroding, it had to have pushed at some point. But if it's just pushing, it's a little controversial.
Yeah, I hope that's accepted, because I've promised in 2 separate talks that data are coming for this. So yeah, fingers crossed.
That was a great survey. I mean, I think should get accepted. So just adding to a few points, instead of what Michelle shared, like residents, they normally do not cut it through again. They just bivalve it, and they have like 2 pieces. And instead of taking more sections, they have to kind of absorb those areas more meticulously by giving a little more slices. And whenever it is more than 7 centimeter, most of the time we'll have renal sinus invasion. My threshold is very low to call it renal sinus. If it's a big tumor, it is kissing the fat, I would call it a renal sinus invasion rather than waiting for and again for a clear cell.
Looks like there's a good question on the Gerotas.
It's probably valid for all specimens. It's not just kidney, because where you see specimens where only one slice has been taken. A lot of sections have been taken.
Yes,
but just from one single
place, slice is applicable to any organ, actually. Yeah.
So I think that's something I think, as from macroscopy we would emphasize, is to take thin slices, examine carefully, and then sample.
Yeah, observe it, then sample it. Yeah.
Yeah, exactly. Differences between grossing protocols for RCCs and urothelial tumors. I think there'll be significant differences, I think, isn't it? One would be obviously that you'd be looking more for whether the renal, if you've got a pelvic calyceal tumor, the question is whether it's invading into the kidney, because that would obviously change the stage. So that interface. For urothelial carcinomas, pelvic renal carcinomas, you're looking for T3 disease if it's extending outside into the fat, right? But you're not looking for things like sinus fat invasion per se, right? So it is about there it's about T3. So if the tumor is invading the sinus fat, it becomes T3, right? Okay. I've got that there. Let me just make sure I've got no other. So what is the best way to determine Gerota's fascia, especially if you have exaggerated perinephric fat? Michelle, what do you do? Like the Gerota's fascia, it's largely a clinical thing. It's a surgical thing, isn't it? Assuming that if you got the outside, the plane that the surgeon would go would be the Gerota's fascia.
I never call it. It's almost, it's sort of, as you said, it's more of an anatomic location. The surgeons are using it as they do their surgery, of course, includes the adrenal gland. We can't see it with our naked eye. I'm not even sure we can see it with a true sections of it. The truth is, what you just want to do is, it's really much more important to call a margin positive. So you ink the outside of the soft tissue, and you're going to say whether tumor extends to that margin, which is a very uncommon finding. So calling T4 based on Gerota's fascia is very, very uncommon. The more common scenarios would be either A, you've got adrenal gland and you've got direct invasion of the adrenal gland as one, or occasionally when you're going to be talking about going through Gerota's fascia is when you've got a very large mass and it's encasing a lot of the kidney and the structures around it, and they may have to take muscle, psoas muscle, or some other anatomical structure. If it's high up in the upper pole of the kidney, a rib resection. I mean, these are very, very uncommon findings or uncommon surgeries these days. But if they take other structures and you're directly invading into that other structure, muscle or something else, then you have to go through Gerota's fascia to get to that other structure. So it's not something that I really look for on a day-to-day basis. I'm really looking for T3 disease, inking the outside, looking for soft tissue resection margins, unless you've got another organ. Potentially the spleen is attached, part of the liver is attached, and it's invading directly into that organ. Your T4 by definition by going into the next organ or skeletal muscle. So I wouldn't focus too heavily on Gerota's fascia per se.
And those would all be very high risk patients anyway. They're going to be
They may not even get a resection in that circumstance and just go, especially to these days, going to immunotherapy or chemotherapy, or TKIs.
How do you evaluate IVC involvement for T3B? Do you require microscopic adherence to the vein? Yes, I think it's generally accepted, isn't it? That if you simply got a vessel and you got tumor in the lumen, that's not enough to call it margin involvement. So if you want margin involvement or vascular, it has to be involving the wall of the vessel. This would be vascular invasion, but it would not be margin involvement unless it's involving the wall of the.
Well, I think the question that's one of my that was posed, and that's my former fellow there posting that question, and we actually just had this discussion a couple of weeks ago, and actually it's not so much the 3A, it's the 3B. So, and I'm actually interested to hear, because I told them how I do it, but from the panel. So if they don't tell you it's a segment of the vein, the actual vena cava, but clinically it is 3B. Do you call it 3B, or do you just say it's at least 3A and just say by report it's invading?
I would personally, I'll go at least 3A, but the way I would word it, because by the TNM rules, you go by what is the lowest, the minimum that you're sure that it is. So that's what.
Well, I mean, they say this thing is tracking up into the heart, or down to the diaphragm. It seems a little silly to call 3A, but just say at least 3A. If they know it's already a 3C or B or whatever, but if they don't rarely give you a segment of the vein.
So what we are giving,
vena cava.
Correct. So what we are giving is a minimum P stage. The P stage that we are giving, you're saying that is the minimum. It can be greater than that, but it's not less than that. So this is the minimum what it is.
Basically, if they submit a sample that's like kidney is part A, lymph nodes is part B, and part C says vena cava IVC thrombus, then I will call it tumor in part C, and I will stage it a 3B.
Of course.
But if they just say clinically it's in the IVC, but haven't labeled something IVC, and all I have is kidney and nothing else, I will stage that T3A. The way I look at it is what we do for a pathologic stage is what we can see on the down the microscope, the gross involvement of the specimen that we're receiving, and then they will clinically stage the patient differently, because clinical stage and pathologic stage are not always the same. The patient could have a nephrectomy that I'm calling T3A, and they could have a lung met. So they're M1 and they're clinical stage 4. But I'm not saying it's M1 because I've been told by radiology that there's a lung met. So I treat it in the same way. If I don't have a specimen with that label, I only stage it based on the specimen that I have or based on the labeling that they've given me. So if they don't mention the IVC in the specimens I've received, I call it a T3A.
Right.
And when these cases come up and you have questions around them, Tumor Board is a great time to explain to them that under AJCC rules, we are only supposed to stage based on what we have and the information we have.
Right.
And you're less likely to receive specimens labeled vascular thrombus without any other specification in the future, because they've appreciated, what we're trying to do on the back end.
Right.
Okay, I'm going to, what we'll do is just in the interest of time. So I'm going to leave the rest of the questions. I'm going to go ahead with my presentation, and then we'll take the rest of the questions at the end together so that we don't, overrun too much. Okay, so I'm going to now move to prostate and bladder. Get that up there. I hope you can see my slide. All good?
Yes, all good, Murli.
All good. Okay, perfect. Okay, so just the first point is, I think, yesterday I talked a lot about the general principles of grossing practice. And I think all these general principles are just as valid in the bladder, the prostate, the kidney, and whichever other organ you're doing. So I would strongly recommend that to go through this paper, this review paper in the Journal of Clinical Pathology, which addresses many of these basic issues. So what am I going to talk about today? So this is not a how-to session, okay? So I'm not going to tell you how to grow a prostate or how to grow a bladder. So we are going to discuss more in terms of the general principles, what is important, why is it important, certain issues, so not the obvious steps in grossing, some issues, and then I'm going to give you some suggestions. Take it or leave it. So as usual, I give you my opinion. That doesn't mean that you have to accept it. All I ask is that you do consider it. And then, of course, we have got our wonderful expert panel. So what I'm going to do at every section, where many of the places I have got my opinions, which may not be the standard dogma or the accepted practice, and it would be nice to get other opinions into it. So when it comes to prostate, I will be talking about macroscopy of needle biopsies, TURPs, and prostatectomies. Prostate biopsies. Now, macroscopy of prostate biopsies is not something that is generally done by pathologists or trainees or advanced practitioners or PAs. It's left to the at the small bench. Now, but with prostate, there are certain issues, I think, which we haven't really discussed. So one of the important things in prostate is the number of biopsy cores. The number of cores and the number of positive cores are both used for risk stratification. So if you look at the NCCN guidelines, so you can see the very low risk is fewer than 3, or very high, more than 4 cores. So the number of cores involved does affect the risk stratifications of patients with prostate cancer. And even the number of negative cores can also be relevant, the total number of cores, because some of the mammograms use a fraction of the biopsies with cancer. So it's not just the number of biopsies, but the fraction of the biopsies. So both the number of positive cores and the total number of cores can be clinically significant. But there's a problem here. How are we supposed to know the number of cores? Because the pathologist cannot determine the number of biopsies. Now, whether this is a pathologist or whoever is handling it, cannot determine the number of biopsies if multiple cores are submitted in a container, because cores fragment. So if I've got 3 core frag pieces in a container, I have no idea whether this was one biopsy which is split into 3, or they have actually taken 3 biopsies. So the only person who knows that how many biopsies were taken is the operator. So the operator has to tell us how many biopsies they have put into each container. Otherwise, you could end up reporting more cores positive than were taken. So let me illustrate a problem here. You got a patient with a T2A lesion on MRI with a 10 biopsy protocol. Okay, this is just an imaginary protocol, a 10 biopsy protocol with 5 biopsies from the radiologically identified abnormality. All 5 of the targeted biopsies were positive. The remaining cores were negative. So how do we report this as? 5 cores positive. If you report it as 5 cores positive, the patient goes into a pretty, as with the NCCN guidelines, it will be more than 4 cores positive. So that obviously doesn't make sense, because the number of positive biopsies reflects the biopsy protocol rather than the tumor size. So if they've seen a lesion on MR and took only 1 biopsy from it, it would have been 1 core positive. If they took 10 biopsies from that one site, it would become 10 core positive. So that clearly cannot, risk stratify the patient. Now, this has been clarified by Gups and ISUP in the 2019 papers, where they clearly said that if you got multiple cores from a targeted site, to consider that as 1 core and to consider it as 1 core positive. But we have another problem. Now, sometimes what happens is, if I have a lesion they have seen on the MR and they take a separate targeted biopsy, but sometimes a lesion that they have seen on the MR is on the same site, which would be normally sampled in the systematic biopsies. So the targeted biopsies then may be included with the systematic biopsies. So they're submitted as right apex biopsy. They don't tell us that these 3 cores that they've taken from the right apex was from a lesion which they had seen and targeted. So the pathologist may not be aware which biopsies were targeted at the lesion. So this information is often not provided to the pathologist. So in Cardiff, what we've done is we've changed our request protocol. So our request form, the form that the clinicians fill up, so it's a tabular form. So it's because they've got their standard sites they take. So that is being pre-printed. There is place for them to add more sites, and they can delete out sites if they don't take it. But then we add these 2 columns, and in that we ask them to say that the number of biopsies they have taken from each site. Now, sometimes what happens is they take 1 core from the right apex, and they think, God, they didn't get enough there, or it wasn't a proper biopsy, and they take another biopsy. They're not targeting it, but they've taken 2 cores only because they weren't sure whether the first core was good enough. So it's useful for us to know that even if it's not a targeted biopsy, as to how many biopsies they took from that site. And then we ask them to tick if any of these sites included targeted biopsies. Now, if they've taken separate targeted biopsies, they would go down at the bottom in a separate row. And our final, what goes out now, this is in progress. A special thank you to Tracy Elsom in my laboratory, who's prepared this dummy report for me from a Welsh dragon. Now, we obviously got some very brave urologists who are willing to needle a Welsh dragon. And I can assure you these Welsh dragons can be pretty fierce, right? But what we have here, you can see it clearly would tell us that from the right apex, this was targeted. So they had seen a lesion of the right apex, which was targeted. They had taken 3 cores from the right apex. Now, we also put in what we saw in the lab. We saw 4 cores were received, but there were only 3 cores which were sent. So that information is there in the report. Now, the other advantage of having this tick mark and then saying which was a targeted biopsy is when I get these set of prostate biopsies, I first look at the targeted one. Because if the targeted biopsy has got cancer, then I can go more quickly with the rest. I no longer have to look for high-grade PIN. There are lots of things I can go more quickly on with the repeat biopsies. So that is a bit, I think, a useful bit of information. And finally, in Cardiff, we do not report the number of cores positive. Because as I said, if you take 5 cores from one site and say 1 core positive, we consider 1 core. So instead of that, we word it as sites positive, and we report the number of sites positive rather than number of cores positive. But this is a Cardiff protocol based on our practice, because for us, each site is provided to us in a separate container. So that works for us. Now, if you get 5 cores on the right in one container and 5 cores on the left in one container, then you got a problem of which sites. That can be harder for you to report that way. But if you've got those 5 cores on the right side, it's very important to know whether did they really take 5 biopsies, or were there 4 biopsies, one of which fragmented and then appeared as 5. So that information is still very, very important. Right, so let's take a break here and get our panel to have a chat about this. So this is, I think, an issue. I think, so as I said, we have changed our request form so that the clinicians provide us with this information, and we then include this information in our biopsy result. So what do you guys feel about it?
So maybe I can just start off first. I can share that we're quite fortunate where we practice that the urologists and the radiologists who perform the biopsies actually label all the biopsies carefully and in different bottles, and therefore the laboratory just follows the labeling that has been given, and we report based on the individual cores that are specifically identified as originating from the specific area of the prostate. So they do label systematic biopsies versus targeted biopsies, and when there's a region of interest.
Yeah. But how many, would they tell you how many biopsies they have put in each container?
Yes, they would. They would sort of like indicate. And sometimes it fragments, and we do, so like mentioned in the histology that it is fragmented.
Yeah,
so
but they would tell you that number. I think that's the important thing, that they do tell you whether they have, and they tell you if they've got a targeted biopsy in one of their systematic sites. So they would let you know. Yeah. So so you're lucky. So if you get urologists who tell you that automatically, good for you. But for many of us, I think we have to prompt them. So we need a form where that's right in their face, and they have to fill up the form and they tell us. For us in practice, if we leave it to them to leave it in blank and expect them to fill it up, they'll do it for 2 weeks and then they forget.
Yeah.
What's the other's experience?
So Murali, we have a similar situation in Sheffield where we're quite lucky, and the urologist will tell us how many cores we get. We get a variable amount of clinical information. I have a question for you with your approach. We will often get trace-seed MRI reports on the front that will say, PIRADS 5 right anterior, PIRADS 4 left posterior, but then a sextant biopsy protocol. So in that situation, I don't take any of those as targeted because they followed a biopsy protocol, but they've told us 2 MRI regions of interest. How would that fit with your approach?
Yeah, so it depends. So with our approach, if they had seen the lesion on the ultrasound, right? So there's 2 types of targeting that they really do. So one is if they've seen an MRI correlate on the ultrasound and they have targeted that area. That's one type of targeting. The second targeting is kind of cognitive targeting, where they have not seen anything on the ultrasound, but they try to target the area where the abnormality was seen on the MR. Now you got the third technique, which is a fusion technique, where they fuse the MRI and the ultrasound, and that is obviously much more reliable targeting. But the key point is they have to give us that information, and I think that information should be there in our report. So when we report it, so this was our mechanism of doing it, and for us, the other big advantage of doing it this way, it is now tabular. So instead of it going into 2 pages with a long description of each one from 2 lines, it now we present it in a tabular format. So it's neater and easier to spot what we want. So this is essentially just a suggestion. Again, it's purely a suggestion. Okay.
So I can just say really briefly that we are told nothing. So by our urologists, and I don't know if it's the United States versus Europe and other locations or not, but we don't get told anything. My approach to this basically is still that truss biopsies, the standard of care for truss biopsies is 12. So if I have 12 parts, it's 1 core per container, even if it's fragmented. If I have 6 parts, it's 2 cores per container, even if it's fragmented. If I can basically reconstruct based on those numbers, then I will mention 2 of 2 or 1 of 2. If it's completely fragmented into a lot of pieces, I just say X% of the total tissue. And that's the truth for the targets as well. So once the 12 truss biopsies come, and then we have the targets after that is usually how our urologists do it. We just give % of total tissue for all of our targeted lesions. We are not reporting individual core percentages. So it doesn't matter if it's fragmented or 5 beautiful cores, it's total tissue, so that's counted as 1 extra core or 1 extra specimen for that target. And that's the way we approach it.
Again, I think, for the audience, I think it's very important to realize that all of us, so whether it is kidney or testis or prostate, all our practices are based on the clinical practice. So when I do something different from Michelle, it's not that one is right and the other is wrong. It's because our clinical practice is different. And so don't automatically do things because Murli does it this way or Michelle does it that way. So you've got to understand why we do it. Each of us does it our way, and then you've got to see what fits best in your environment. Okay, let's move on.
I think it comes back to what Stephen said earlier, is that this is where communication, whether it's tumor board or you say, like, call your clinicians, you start when you meet your clinicians, you talk to them and get an idea of what's happening, what your expectations of them are, and vice versa. And that communication helps put it all into perspective and the best practice.
Yeah, when I started in practice, even before I was credentialed. Oh, I'm sorry. I was going to say, when I started in practice, even before my credentialing went through and I was verifying cases, I went to my first tumor board and I was like, all right, urologists, let's sit down and get our ducks in a row. In each jar you're putting, and they said always and only 1 core unless it's labeled a target. So I know how to approach it and I know how they're going to count it. Because if I accidentally say 20% of 2 cores and it's fragments, if you go by national practice guidelines, you might be impacting someone's active surveillance criteria. So you've really got to know what you know. And when reviewing consult cases and transfer of care cases to our cancer center, I very often will describe it as involving X percentage of the tissue sampled from this site, with a comment that I can't vouch for what their intention was and that I'm not going to make it into cores for that reason.
Yeah, so I think it's all of this is about getting the information and reporting that information. I think, as I said, one of the big problems we have is the turnover, especially with like the junior urologists. So you tell people, and the person who fills those forms is often not the senior urologist, and then you get this variation. So you get this tumor board, you get all this explanation, you think you've sorted it all out, and 3 weeks later, you get cases where they're forgotten. So which is why we like to have templates in there, which forces them to put the information in the spot. Okay, let's move on. Okay, let's put it in there. Okay, so we are now going to move to TURPs, which is the bane of our life, I think. I think most of us will agree that the greatest challenge with TURP specimens is not finding prostate cancer. At least in my experience, the biggest challenge with TURP specimens is staying awake, right? Because most 99.9% of them don't have cancer. There are a lot of slides, you're screening them, and you're just, it's hard work staying awake. So is it what we are doing really necessary? So this is our guidelines in the United Kingdom. Okay, so we still go. I think it's a bit whether this is outdated. All up to 12 grams. So the first up to 6 blocks, you would submit everything, and then 1 block for every additional 5 grams. Which means if you got a 25-gram chippings, you get about 9 blocks. A 70-gram chipping, 19 blocks. So let's have a think as to why are we putting these sections in? Are we trying to identify what is the cause? This patient had urinary retention. Usually he's had medical treatment. He has failed medical treatment, and which is why he's had a TURP. So are you trying to find out why he had the retention, or are you trying to find incidental prostate cancer? So if the tumor is large enough to cause retention, there's going to be plenty of tumor there. So a few blocks would find the tumor. So more extensive sampling is to detect incidental prostate cancer. And when you look for cancer, if you have a protocol which is designed to detect incidental cancer in whether it is radiology or any other testing, that is screening. And we don't have consent. The patient has not consented for screening. He has consented for histological examination of the tissue, but not for screening. So this is where we had a couple of we published a few papers earlier where we questioned this practice. So the counter argument is that the patient has consented to histological examination, but it's like PSA. Just because you got the patient has consented to do a blood test. It's certainly in the United Kingdom, they cannot tick the PSA box. They have to counsel the patient about the risks of incidental cancer before they tick the PSA box. So you can't do a PSA test without an informed consent, which requires counseling. Similarly, but for patients with TURP have not been counseled about whether they want to be screened for cancer. And you've got this situation, the extreme situation where a patient has refused PSA testing, and the same patient, if he undergoes TURP, then gets screened for incidental cancer. And this is not the same as taking background blocks, where you take a few background blocks from the breast or the lung or the colon. Because here you got a sampling protocol that has been specifically designed to identify incidental cancer, or most of the incidental cancer. So here's a recent paper from 2022, where they looked at, they said you to submit 10 cassettes because that would identify 96% of incidental cancers. So if you've got a protocol that is designed to identify almost all incidental cancers, then in my opinion, that would amount to screening. So looking for incidental cancer in background blocks is analogous to finding a kidney tumor when a patient comes with abdominal pain and you do an ultrasound examination and you find a kidney tumor. That's an incidental kidney tumor. That is okay. But finding incidental cancer in a TURP is just saying that because you got a patient who's come to you for an MRI, I can do a whole body MRI. No, you can't. So, but I think we have to reconsider whether what we are doing is appropriate. Entirely, that early detection of prostate cancer could well save some lives. But it's exactly the same like when you go to the doctor. What does the doctor do? He takes your clinical history, does a clinical examination, and then does investigations. All of these are targeted. So based on your clinical history, he would do the clinical examination. Based on the clinical examination findings, he will ask for the investigations. He would not be screening you automatically for things. So, in an extreme example, if your GP, a general practitioner would do a knee reflexes on every single patient who came into his office, yes, he will find some early neurological disorders. But there's no way that he's going to do a knee reflex test, knee reflexes on every patient. So a routine DRE may detect localized prostate cancer. A routine PSA test may detect early prostate cancer. A routine bone scan may detect early metastasis. But that's not a reason to do any of these tests, because these would neither be cost effective nor would they be ethical. So this is where a paper which we had published some years ago, where we compared clinical practice with histopathology practice. And I think histopathologists would do well to take a few lessons and to learn a few lessons from the clinicians, and to consider working to consider the clinical utility, to consider the cost effectiveness, to the various things in this paper that we said. And then finally, when it comes to prostate, you got the new technologies for treating BPH, where they do electrovaporization of the prostate. So when they vaporize the prostate, there is no histology at all, because there is no material for histology. So there we have no problem about not examining any tissue at all. While on the other side, when they give us tissue, we examine a lot of tissue. So I think this is something that we have been actively taking forward. And I'm pleased that we had this series of experts who have agreed, I think, on principle, that the current protocols are inappropriate, that the current protocols for sampling TURP specimens are excessive, and we probably need to reduce the number of samples, number of blocks that we take. But however, there was no consensus on how low should be low. So there are various opinions, and I think this needs, but there was a consensus that this needs further debate, more discussion, probably involving both ISUP and GUPS, to come to a better way of sampling these TURP specimens. And then we got this question of how many blocks of a TURP specimen should we take? Again, we have to come back to basics. Okay, when I say I'm going to take 10 blocks, what do I mean by a block? A block is not a standard measure of specimen extent. When I say a block, it tells you nothing about how much tissue I've examined. All of these are one block. So it could be one chip, it could be a small number of chips, or I could stuff the chips, stuff the cassette with chips. All of these would be counted as one block. So a block is kind of meaningless as a way of saying how much of the tissue you have examined. Just one small important point: when you're doing, sometimes pathologists or whoever is doing the macroscopy thinks they're doing a good job by filling up that cassette with chips and absolutely stuffing it. But don't forget, you're only examining 1 5-micron section from it, and the rest of it will remain inside, and that's a problem, because later, if somebody goes, the slides are not to be found, and somebody takes a recut, they're going to take a deeper section. So most of those sections will not be examined. So don't fill up that cassette. You put enough to have one layer of chips to be sectioned, but don't stuff the cassette. And then eventually, how much are we really examining? So here's some calculations for you. If I take a 25 grams chippings and I all embed it, according to the, it'll be 13 blocks. So about 2 grams for each block would be 13 blocks or 13 cassettes. Each cassette, you would have examined 1 5-micron section of a 4 millimeter, 3 or 4 millimeter piece of tissue. That would amount to 0.13%. So what that means is that if you all embed the TURP specimen, you still have examined only 0.13%. That's a tiny, tiny, tiny fraction of the specimen. So instead of embedding 13 blocks, what happens if you embed 9 blocks? You would have examined 0.9% of the specimen, which means you have examined 0.04% less than the all embedded. If you take only 3 blocks, you would have examined 0.03%. So which means between all embedding 13 blocks and taking 3 blocks, you have taken 10 extra blocks to examine an additional 0.1% of the prostate to find incidental cancer. So again, you can see that what we are actually doing, we need to think more about what we are doing and whether we need to change. So to conclude, TURP sampling only samples a tiny fraction of the TURP specimen. TURP is not a good tool for detection of incidental prostate cancer. If a patient really was worried that he wanted to be screened for prostate cancer, well, then get an MRI done. I'm not suggesting for a moment that all patients with no clinical suspicion of malignancy should have MRI, but that would be a better tool than trying to screen patients with TURPs. Okay, so let's stop here and do a brief discussion on this. I told you I would be provocative, right? And this is provocative, but I think it's important because by taking all these extra blocks, we are harming that patient by finding incidental prostate cancer. So these patients are labeled with the financial and the psychological and all the other implications of incidental prostate cancer. And we've also harmed other patients because all these extra blocks that we take means that the other patients' reports are delayed. So this is something I think we need to consider. So we can briefly, I know time is an issue, but we can quickly discuss if there are points on this. That if not, let's move on. I think I am acutely aware of the time. Yeah,
can I
go
ask
ahead.
a question? You know, when you have this
Of
TURP
course.
specimen and you sample some of it and you find incidental prostate cancer, and you report them, how often would you go back and put the whole thing through?
Exactly. I think it's exactly, for me, it's exactly the same point. So if I find a one chip positive 3 + 3, I don't go back and put any more.
Yeah,
My point is I'm sampling. So if I go back and put more, then I would ask you, why not go back and take levels? Because there's a lot more chips material in there of the prostate that you haven't examined. And where do you stop? Right. And today it really doesn't matter so much because when I report 3 + 3 prostate cancer, the next step, the patient's going to get an MRI, he's going to get a PSA, and they're going to look for clinically significant prostate cancer. So personally, if I find small amount of chips, I don't necessarily go back and put more. We are using the RCPAT guidelines. So we are putting a lot of chips up front, but I think it's my personal opinion. I told you this is my opinion. I'm not saying that this is what you have to do, that I don't think there is a need, because eventually whatever you do, even if you all embed the specimen, you have still only examined 0.13%. You have only sampled the specimen. So we are talking about what is the degree of sampling that you should do. There is always going to be a degree of sampling.
Yeah, I think it's easier to defend not going back for a small low-grade cancer than it is to argue for decreased standards for, protocol review of these specimens. So the regulatory framework in most US states is that there is the expectation that any sample removed from a patient's body has to be evaluated by pathology to prove that, to some extent, the right procedure happened, of course, but also exclude unexpected findings. So it isn't so much a question of they weren't consented, at least for us, it isn't so much a question of whether or not they were consented for prostate screening by TURP. It is that state law requires that specimen to be examined histopathologically for unexpected findings.
Stephen, but what I would say is it's a case of how to what extent it should be examined. So don't forget, like a wide local excision of breast, or even a breast reduction specimen. You wouldn't dream of submitting the whole of the breast reduction specimen because there might be incidental DCIS, right? So you'd always, there is a degree of sampling. So I think it's the same principle. So just like the breast reduction specimen, we don't try to find every incidental lobular carcinoma or in every incidental DCIS, which is clinically significant. The same argument would, to me, would apply for the TURP. So I think this is an issue. I don't think it is an issue that we can solve today in 5 minutes, but it's something that ISUP and GUPS need to get actively involved and get an active debate going. And I'm glad that we've got the debate started. Okay, so let's talk more about prostate sampling. Okay, so now we start to go from the small to the big. Okay, so you've got the whole prostate now, and what do you do with that? Right, again, if you think of it, I can't think of any other resection specimen that is routinely examined in total, right? We don't examine a mastectomy specimen, a colectomy specimen, a hysterectomy specimen. We don't submit all of the endometrium or the whole of the specimen in any other specimen. So what's so special about the prostate that we need to submit all of this prostate? Now, I'll try to go through the history of this and what I think is why we have got here and why we probably need perhaps to consider changing. The reason we got here is historical, because historically what you had there was the abnormality was in the blood, the PSA. So you had a patient with a raised PSA, and we did this random sampling. So we took these systematic, non-targeted biopsies. And then we find cancer in that. The patient got the prostate out, and the pathologist can't see anything, right? So the clinician doesn't know where the cancer was. He knows where the biopsy was positive, but he doesn't know the location of the cancer, where in the prostate there could be cancer other than that tiny biopsy. The pathologist couldn't see the cancer, so the only option was to put the whole thing through. So that made sense in those days. And then we then spend a lot of time on these radical prostatectomies. So a lot of work for the lab with all these cassettes, and a lot of work for the pathologist to assess the prostate. Now let's take a step back and see, is this really warranted? So what's the management after radical prostatectomy? You've got two options after that. It's either adjuvant therapy, which means giving patients hormonal therapy or radiotherapy based on adverse pathology findings, or else what is called salvage therapy, which means you just follow up the PSA, and if the PSA rises, then you treat the patient. PSA is not a great tool for diagnosis of prostate cancer, but it's an excellent tool for monitoring patients for early recurrence after radical prostatectomy. It identifies recurrence long before clinical or radiological metastasis. So unlike breast, lung, colon, endometrium, etc., where the metastasis would be only identified when the patient actually manifests either clinically or radiologically, with prostate, with the rising PSA, we can detect it much earlier. So that means, as far as the urologists and the oncologists are concerned, there is much less reliance on pathology to identify high-risk patients when it comes to prostate cancer as compared to other cancers. PSA identifies early recurrence and metastasis, and because of the location of the prostate gland, adjuvant therapy has significant morbidity. And in many countries, like in the UK, and I think even in the US, PSA monitoring is becoming the norm. And it's like, if you look at the NCCN guidelines, the AUA guidelines, the only patients that they recommend, the adjuvant therapy, is tumor stage and margin. The Gleason score definitely doesn't come into the equation. So it's a lot of work. So quite reasonably, several experts and several groups have suggested partial embedding of these prostates, right? So that you save blocks, save time, save money. And you've got these papers. This is just a couple of them, and there are many more comparing the various ways of partially embedding prostates. The problem with these papers and these studies is that all of these use a standardized, non-targeted, one-size-fits-all partial sampling protocols, and which was reasonable because these were all created at a time when we didn't know where the cancer was. Now, that situation is different now. Today, certainly in the United Kingdom, and it's becoming more common elsewhere, patients get an MR. In the UK, most patients with prostate biopsies get a pre-biopsy MR. In other countries, if they don't get a pre-biopsy MR, most of them would get a post-biopsy MR before the radical prostatectomy. So at the time of the radical prostatectomy, you would have the MRI findings. So if the MRI now shows a lesion at the right mid-gland, a Pyrites 5 lesion, the biopsies are only positive on the right side, you have a fair idea that that is where the cancer is. And then you have the option now of maybe targeting that your sampling as you would do with any other organ. So like in a mastectomy specimen, you don't try to find incidental breast cancer in a mastectomy specimen. You target it based on where you thought the tumor was. So that could be the future. Again, this is a suggestion. It is not, I'm not saying that we need to move to this right now, but it's something as a pathology community, as a uropathology community, we need to discuss this. We need to think about, is it really necessary to examine the right side of the prostate if the biopsy and the radiology was only positive on the left? As I said, very limited sampling of background mastectomy specimens is a norm. We don't. So maybe that is what we need to do. And finally, we got mega blocks. So in many centers, certainly in the UK, I know it's less common in the US, but in the UK, it's very common to use mega blocks for everything. Mega blocks are nice. They're aesthetically pleasing and certainly makes our life easier because it facilitates tumor mapping. So if I need to map out the tumor and draw lines, it's much easier. However, they need separate longer processing. They need separate microtomy, more difficult microtomy, separate storage of blocks and slides. And if you need IHC, it becomes more difficult. It's not impossible. You basically need to, I need to tell them which part of the block needs to be cut. They will take a full section and then cut out that small bit from the water bath to put it into an ordinary standard slide to go into the IHC machine. But those are all adding extra steps and more difficulties. I'm going to skip the discussion just now for this. And okay, let's take this discussion before I go on to bladder. So I think, so this is where I end with prostate. So if there are any comments on this bit. So again, as I said, these are all just suggestions, but I think these are things that I think we need to address because the current practice is simply not viable. I think in the UK, certainly, a lot of the pathology departments are teetering on collapse.
So I guess I will just make the comment that it's, we have to think of prostate as different than most organ systems. In a lung, you can see a mass. In a colon, you can see a mass. In the breast, kidney, you can see a mass. And more often than not, you cannot see the mass in the prostate. And I think that's the issue. I'm sure we've all seen cases that went to prostatectomy that had a 3-4 going into it, and you found a 4-4 or a 4-5 somewhere else in the prostate that was unexpected. And so that's the challenge. So I really think
a challenge.
The issue is, if anything, if you slice your prostate and you want to minimize some tissue sections, that you go every other slice. Because if it's a large enough lesion, as you slice the prostate, hopefully you're going to get a piece of it, of that mass, in even if you can't see it in every other slice or at some point. I know at the Brigham, what we do is we submit the entire posterior zone and we only sample the anterior central zone, and we reduce number of blocks in that way. And then if we don't have what we're looking for, we can always go back. But we try to hold back on the anterior central zone to preserve some time and energy. Otherwise, it's really focusing on areas that are going to increase stage or cause management issues, change in clinical practice afterwards. Margin, if it's a large margin or you see something near a margin, seminal vesicle invasion, those are the things that are going to have major impact on what's done after the prostatectomy specimen, and I think need to be focused on. But otherwise, I actually joke with a lot of people that we can throw the prostate away and just follow with PSAs. Outside of finding pattern 5, outside of looking at the margin, outside of seminal vesicle invasion, which is going to change the hormonal therapy after the radical prostatectomy, what's inside, it's pattern 5, seminal vesicle and margin that matters most. But we don't want to miss those things, because if we do, there's significant impact on the patient. We don't want to just find the elevated PSA when it's already in their bones. So, but I do think there are ways that you can minimize, and again, just knowing that the approach is different, because we can't always physically see a mass, and more often than not, you're just seeing BPH nodules.
Michelle, I think my counter argument to that one would be, we don't need a standardized approach. There are some cases where you can, some cases you can't. Like lobular carcinoma of the breast. We know they can't see it properly mammographically. Even in a wide local excision, we don't submit all of the wide local excision because there may be an incidental lobular carcinoma somewhere. Forget about the mastectomy. But the other side is, even if you miss the high-risk tumor in the prostate, these patients will get a rising PSA. And today, it's not like the old days where they used to wait for the PSA to go to 1 nanogram per ml. Today, if it goes up to 0.4, they would treat. So they treat actually very early. So long before the patient gets any metastasis, he would get adjuvant therapy. So that the cost, so if we don't detect the high-risk cancer upfront, the penalty for in prostate is much lower compared to the endometrium or the breast, where the patient might come back with metastasis. So these patients would still be treated relatively earlier.
Well, there's
so
no
I think
doubt
again,
we should all be very thankful for PSA, despite its controversies. We should all
yes,
be
I think
thankful for serum
I totally agree. In the
wish every organ had
prostatectomy
it,
setting, right? PSA is great, because once you've removed all the benign prostate, the PSA works, isn't it? Okay, let me now move to the bladder. I'm going to be more brief with the bladder, and I'll be largely talking about, let's go to this. Okay, right. Bladder, again, we got a lot of data that we collect. Again, we need to think of clinically. How the patients had a cystectomy, what really matters? Neoadjuvant chemotherapy is standard now in many institutions. So what are they going to do with the prostate, with the cystectomy path data? It's for treatment, for the follow-up protocol, and limited management implications. So today, the management implications from a cystectomy are relatively limited. So again, the two options they have is adjuvant chemotherapy based on adverse path findings, or to follow up and treat the patients only. Now here, they don't have PSA. So here you're talking about a patient coming back with local recurrence or with metastasis. So what does our guidelines say in the UK? So the NICE guidelines says that you've got the option now, if the patient has had neoadjuvant chemo, you've got the option of giving them checkpoint inhibitors, nivolumab. Now that is basically for T2 plus. So why? Because these are post-adjuvant T2 plus or node positive. Or if they have not received any neoadjuvant chemotherapy, then you give them checkpoint inhibitors if they have got T3 plus. So what that means at present, now if tomorrow the guidelines change, that's different. In today's practice, if the patient has had neoadjuvant chemo, then you don't have to look too hard to find CIS or TA or T1 residual tumor. It doesn't change anything. If the patient has not had neoadjuvant therapy, again, the only one that is going to change management is T3. I'm not saying the rest of it has no, some of it might have prognostic significance, right? But it has no management significance. So again, we should be focusing our resources on things that can impact the treatment of the patient. Now, if you are dealing with clinical trials, it's slightly different, because there you might be interested in the T1, in the residual TA or T1 disease post-neoadjuvant therapy as an endpoint for clinical trials. Now, that is different. But if you're a practicing pathologist in a community hospital, you certainly don't have to worry too much about early disease. Now, again, there has been like in other organs, there's been a suggestion of the tumor regression grade for urothelial carcinomas. This is not commonly used in clinical practice, so currently it is not required. Now, in contrast to that, pathology is more important in uretrectomy and nephrouretrectomy specimens, because in these specimens, the patients do not get neoadjuvant chemotherapy. So in a uretrectomy specimen, it is critical for you to look for T3 disease, because if you find T3 disease in a uretrectomy specimen, the patient would get chemotherapy. If you find T3 disease, which is in a renal pelvis tumor going invading the renal parenchyma, that patient would get chemotherapy. So that becomes absolutely critical. So what I'm trying to get here is that staging is more critical in the upper tract than it is in the cystectomy specimen. I'm not saying that cystectomy staging is irrelevant, but I'm saying it's what is more important. So when you're doing a cystectomy, the first thing you got to know is, why was a cystectomy done? You'll get occasional cases where the cystectomy was done for symptoms of BCG. The patient had BCG, then because of BCG, he's got severe BCG symptoms. He gets the bladder becomes contracted, very painful. He's got to keep going to the toilet. And these patients then it's so bad, they end up with a cystectomy. In those cases, you don't have to sample a lot of sections, because there is no clinical evidence of residual tumor. They're doing it as a therapeutic procedure. It is useful for us to know the location of the tumor before you do the cystectomy, where the tumor, before you examine the cystectomy, either by the cystoscopy or the radiology. So when you sample the cystectomy, so you've got three things you got to think about: sampling the tumor. Sorry, let me just get rid of this. The tumor, the background bladder, and then the organs that come with it, either the prostate or the uterus. So let's deal with this. So you've got three different scenarios here. You could have a cystectomy with a visible tumor. You could have a cystectomy where there's no visible tumor, but you can see the scar, or you can see the TURBT defect, or the area where the TURBT is done. So you know where the tumor had been, and you get a cystectomy where you can't see any abnormality at all. So these are three different scenarios. So how do I deal with this? So if I've got a visible tumor, you don't need to sample all of the tumor. So you're basically focusing mainly whether if it is neoadjuvant, you're looking for T2 disease. So you're looking for, you're taking more sections from the deeper part of the tumor for looking for residual T2, YT2 disease or T3 disease. If you've got a scarred area and you can't see any tumor, usually this area of scarring is small and you can easily put it in a few blocks. Yes, put it in a few blocks. But again, the focus has to be on, if you're going to put larger number of blocks, focus on looking for, don't take blocks to look for TA and T1 disease. If you see no abnormality at all, it's a good idea to check the clinical and radiology. Did they see it? Usually after the neoadjuvant chemo, they would have done another CT scan or an MRI. Check what the post-adjuvant therapy CT scan. Did it show any residual tumor? If there was nothing seen residual tumor on radiology, I would fix the specimen fix it properly, take very thin slices, examine it very carefully, and then if I don't see any residual tumor, I would not bother to extensively sample it to look for residual, incidental, tiny bit of tumor. So my approach, so that's with the bladder. Now moving on to the prostate. Again, I think there's a difference of practice within the UK and the US. My understanding, speaking to US pathologists, that complete sampling of the prostate from cystoprostatectomy specimen is not common practice in the US. But in the UK, it is common practice. I know of in many centers where they would put the entire prostate through. So my own approach is that I would focus on that cystectomy assessment should be on the focus, should be on the staging of the bladder cancer rather than detection of incidental prostate cancer. And I would tailor my approach based on the tumor location. So if I've got a tumor which is located at the base of the bladder, near the trigone, right? So either I can see a residual tumor at the trigone, or radiologically, or the previous thing, the tumor had been in the region of the trigone. Then I take these sections from the trigone, into the base of the prostate, to look for direct extension, whether there's any direct extension of the tumor into the prostate, because that would make it PT4. However, if the original tumor had been well away from the trigone, had been well away from the prostate, I don't bother to sample the prostate bladder interface, because there's no reason to suspect that there is direct invasion of the prostate. All embedding the prostate gland, the arguments against it is that the patient outcome is determined by bladder cancer rather than prostate cancer. So here is, I think, the only really good paper that I'm aware of on this. It's a very large number of patients followed up for a very large period of time. So 1,640 patients with a median follow-up of almost 10 years, right? They had one prostate cancer death. In contrast, you had 127 bladder cancer deaths. So the chances of prostate cancer deaths after prostate cancer is extremely low. So it is not cost effective to sample the entire prostate. Again, we don't, so it comes back to the same thing. What you're doing, if we sample all of that for looking for incidental prostate cancer, like the TURP specimen, I would argue you're sampling for prostate cancer. Now, again, this patient's got a much more serious cancer to worry about, the muscle invasive bladder cancer. But even so, all you're doing is adding another cancer to his list of things for no purpose. And then when it comes to the uterus and the cervix, we don't all embed the cervix to look for incidental cervical cancer. We don't all embed the endometrium to look for incidental endometrial cancer, which could be endometrial, could be serous carcinoma incidental. We don't do any of that. So what's so special about the prostate? So my approach, I do not sample all of the prostate. So what I would do is, to me, what's more important than the prostate is the urethra, because whether there's urethral CIS. So if I got a urethra, I need to examine the urethra carefully, because if I find a urethral tumor there, obviously that becomes important. But if I don't see any macroscopic abnormality in the urethra, I am more interested in identifying urethral CIS, because that could have implications, especially if the patient is having reconstruction surgery, because that increases the risk of recurrence later, of urothelial carcinoma recurrence rather than prostate. So what I do is I slice the prostate this way, and I would take these sections of the prostate, which includes a long strip of the urethra. So I don't submit all of the urethra, but I do get more of the urethra this way. So my focus would be submitting of more of the urethra rather than of the prostate. And so when it comes to finally the ureteric sample, again, meticulous gross examination is the key. Sample any gross tumor in the ureter, in the cystectomy specimen. Sample for CIS, but again, this is entirely sampling error. So you take a couple of sections of the ureter. Even if you were to all embed that ureter, as I said, you've only examined 0.13% of the ureter if you all embed it. So you're examining tiny, tiny fragments. By putting 3 pieces of the ureter or 4 pieces of the ureter, you've actually examined very little. And then the margin status. So it's very common to take ureteric margins. But what does this really mean? Because CIS is not unlike tumor, CIS is not a continuous process. CIS is a discontinuous change. It's a field change, which is discontinuous. So just because that random line through which the surgeon's scalpel went through did not have any CIS, doesn't mean there can't be any CIS on the other side of that line. So I personally, fortunately for us, we are, I think in the UK certainly, and I suspect I would be interested in your experience elsewhere, ureteric frozen sections have become vanishingly rare. So I can't remember the last one. Certainly in the last few years, I can't remember a ureteric frozen section. I will end there, and let's have a discussion on these points. As I said, some of these will be provocative, and certainly opinions, okay? Right, who wants to go first? If you it may be a good idea to use the raise hand function so that I think sometimes what happens with this when we are as a group, we are all afraid of talking over someone else, isn't it? So if you want to use the raise hand function, and then we can discuss. Okay, so if there isn't, so let's do one thing. Let's quickly go through the Q&A questions. What are there? In case of regression in a germ cell tumor, what additional growth features need to be documented, if any? This is for a testicular tumor. If there's regression, I can't think of anything specific from growth examination. So if you've got regression, you try to embed all the area of regression. So you try to embed that whole area of fibrosis and to look for what. Now, obviously the key question here is once it's regressed, you don't know what has regressed, whether it was a seminoma which has regressed or a non-seminoma which has regressed. Or if it's a non-seminoma, what were the components of the non-seminoma? So all you can do is to tell them there is a regression. It's like melanoma, isn't it? When you get regression of a melanoma, we have no idea what was there. Does anyone else have anything?
It sort of depends on the circumstances under which it comes to light. And, you know, a lot of our testicular cases are sort of referred in, and at the time they get here, you have relatively limited clinical information, etc. So I, generally speaking, when it comes to the gross bench, don't necessarily have the proper information to know that it is going to be a regressed case. And this is sort of a what might you go back to the bucket to look at kind of question for a lot of these.
Yeah, so a lot of these you may go back and take more sections from that, I guess, isn't it?
I think a lot of times, not exclusively, but regressed tumors show up when the patient's already presented with a metastatic lymph node or metastases to the retroperitoneum, and then they go looking at the testis after the fact. But if you get one prospectively, I don't necessarily think you have to put through the entire scar area. If it looks completely fibrotic, I mean, first and foremost, it may not be a germ cell. It could be something like Sertoli cell tumor. But once you've sampled a few sections, if it is all scar, then I actually prefer to focus on the interface, because scar plus GCNIS is a diagnosis of regressed tumor. And if you're not seeing anything that's fleshy or necrotic or viable, then having scar plus GCNIS is enough. And I'm actually looking for GCNIS. So getting that interface of the scar to the surrounding tubules, which is a little bit of random sampling, is what I'm actually more interested in.
Yeah,
I think that's
GCNIS and teratoma, if it's present there, where you find a small cystic focus or something, it tends to be what survives if it's a post-chemotherapy one.
Yeah, the other one with regressed, I think it's always useful to check the AFP level. If the AFP level is significantly, especially if the AFP was raised and has come down after the orchidectomy, so you can be fairly sure that the source of the AFP was from the testis. These patients almost certainly have a non-seminomatous tumor, and they would be managed as a non-seminomatous tumor, in which case you don't have to bother to go and take a lot of sections and whatever, because whatever you call it, even if you were to report it as regressed, they're going to simply treat the patient as a non-seminomatous tumor. Yes, I think the message I think we are trying to get through, all of us, is the clinical-pathological bit. That pathology is only one aspect of it, and you've got to put it in the context of the whole case. How would you measure a cystic tumor? Wow. This actually is quite a complex question, not the measurement. No, you measure the cystic tumor as you would do like any other tumor, isn't it? So you measure it. But the bigger problem with these cystic tumors is when you use that for stratification. So if I've got a renal cell carcinoma, which is predominantly cystic, it's more than 7 centimeters, but it's more than 7 centimeters because it's full of fluid, right? We know that cystic renal cell carcinomas have a better prognosis, right? So so does this patient become high risk because of the size of the tumor? Moot point. But this becomes more important in the thyroid. When you get a papillary thyroid carcinoma, which is predominantly cystic, and you say it's more than 4 centimeters, so it's T3, the patient gets a total thyroidectomy, and thyroxine replacement for life, purely for a purely cystic tumor purely because it was more than 4 centimeter. I think there it becomes a real problem. And I think it's all we can do in those situations is to tell them, to flag it up to the clinician that this tumor was purely cystic. And, we don't know what essentially the clinical significance of this may be uncertain.
So I think it's all about, as you even alluded to, Murali, is that it's communication, right? We're just trying to communicate with them.
Exactly.
And if you're really uncertain, I'm happy, we'll write a note on a case that says the overall lesion, including the solid and cystic components, measures 8 centimeters. However, the mural nodule measures 3.
Right.
And then you can decide to stage it which way, but you just tell the clinician both measurements so that in a note you communicate, and they're smart people. They're going to know that that's probably more likely to be a T1 tumor and not a T2, big T2 or whatever you tumor. I think also is important to make sure that you're dealing with a carcinoma and not a cystic mimic of a benign tumor first, but assuming that it's right. But if it's truly carcinoma, just give them both measurements, and the mural nodule, the solid component, is going to be more likely to be what's clinically relevant.
Really, can I just chime in with?
Before, I think I would be slightly less worried in the kidney, because where it's only the follow-up protocol that's going to change. It's only where the patient gets an extra CT scan instead of an ultrasound, right? While with some of the other organs, it can have much more serious. Okay. Let me see whether there are anything
Can I just add 2 things that I think it's two important points that are not necessarily highlighted here, because I think it's something that we're all, if you're not seeing it, you're going to see it, is neoadjuvant therapy. Because it completely changes the way you're grossing. I said kidney is coming. I said if you're not seeing it, you definitely probably will be seeing it, where you may see something that's looks like all the world, like it's in, pelvic calyceal or out or whatever, and you sample, it's all fibrosis. So, I think there's going to need some standardization as to, do we need to submit it all in? And Priya Rao at NB has a beautiful paper with some guidelines recently that came out. And then the bladder, like I said, neoadjuvant's been around for a while, but I think, that's, at least here at Stanford, like I said, probably more than half of them are come in neoadjuvant. And I always tell the trainees that, if you're not seeing an obvious tumor and you just see the scar bed, you could just flip a quarter in terms of, is there going to be viable tumor or is there not? Because what you see is almost a complete discord on the glass. So in those instances, Sarah Wapker has a really beautiful paper out of AJCP, just published recently on that as well. Just, again, guidelines. Do you need to put the whole scar bed in? Do you, here we tend to put in, if you don't see anything obvious on the cystectomy, maybe put in half. And then we do submit the residual scar bed afterwards. But again, just some guidelines. But I think the neoadjuvant thing, testis neoadjuvant is less so, and prostate probably less so. But I think especially for kidney is coming, and bladder's already been there. But the neoadjuvant is we need some standardization for grossing.
And also for the post-immunotherapy cases in kidney, Ankur, the cases where they have given the immunos and
any therapy, ICI or
yeah,
any therapy. Michelle had a beautiful lecture earlier this year, I think, with the ISEP or GUPS.
Yeah, I think a lot of this will depend on your local circumstances, isn't it? Certainly, I can say in the UK, we don't see many more. I can't remember, post-adjuvant nephrectomy. These might come in the future, right? So currently, for us, adjuvant therapy is not it's still follow up, and so these might these are certainly worth studying for research purposes and for the future. So but for most people who are practicing, it has to be based on their current practice in their current healthcare system. So,
somebody had asked about the neoadjuvant kidney online, and because I knew we wouldn't get all the questions, I actually typed it in as an answer. So if you look on the Q&A under the answered sections, that's where I put my answer about the neoadjuvant kidney and put in the reference that Ankur just mentioned. Priya Rao is the lead author, but the first author is Michael Huang, and it's in Diagnostic Histopathology is the recent reference on neoadjuvant treatment and how to approach those specimens, the kidney specimens. And Catherine Saunders is the first author for the paper with Sarah Wapker on neoadjuvant bladder cancer. So they're two really good references that are guides. They're not, the end all, but they're really, really good first approaches to these problems.
And Michelle, what is the next step from that? So what do they do what we find. And so, when we, after neoadjuvant therapy, we find...
It's not established. I'm actually going to an oncology meeting to discuss these issues in January. So they're all, right now, I will tell you that the guidelines for further treatment in neoadjuvant kidney tumor, treated kidney tumors, whether it's TKIs, ICIs, combination therapies, is based on radiology. It's not based on pathology. They're making their decisions. The endpoints for the clinical trials are radiology driven. And I've been really pushing at the KCA meeting recently that these need to be pathology and radiology, but they really, you could have a radiographic 7-centimeter mass and 1 millimeter of viable tumor. So I'm really pushing for it in this meeting in January, but this is all, new news, not established guidelines forthcoming.
So I think, for the audience, I think it's very important for you to be able to distinguish between the two, isn't it? So we got stuff like as academics, we are very interested in certain things. We are interested in the future. So a lot of us as academics are focused on what's coming down the line. But if you are a practicing pathologist in a community hospital or even in an academic hospital doing routine practice, you have to be aware of what is relevant for your practice at that time. Okay. Any experience with the transperineal approach and the increasing number of sites sampled and impact on sites and cause positive? I think this thing is a reduction in the number of biopsies. So what we are seeing at least is the number of biopsies. So we did, yes, the systematic biopsies went up from 6 to 10 to 12. So 12 is our standard systematic biopsies we get. But we are getting more targeted biopsies now. I know there are some centers, I think Eamon will tell you more about it, like in UCL, where I think they get predominantly only the targeted biopsy. So if they see some Peyronie's lesion, they target that. Eamon, I'll let you take that.
That's correct, Murli. After the 2019 precision trial results, the shift towards targeted biopsies started. I saw that shift on my table in the prostate cases coming through. And now all the in-house cases that we do get, which is around 600 to 700 prostate biopsy cases in the year, are only targeted biopsies. And we were discussing cores. They also come with their site-specific labeling in the containers. But unlike what you've managed to establish in Wales, we do not get the number of cores positive. We are reliant on the laboratory operators telling us the number of cores. And we give the highest percentage core involved in those sites specific. We do get all other clinical information very nicely because there's a dedicated focal team as well as a robotic team which looks into histo-MRI planning, personalized planning for the surgery, radical prostatectomies of each patient. So we do get very nice site-specific labeling, and we do get very nice information on whether fusion biopsies were used or whether these were multiparametric MRI. And the number of cores is usually 3 to 4 maximum in each pot. And we tend to, see them as consecutive levels on one slide. And that's been the shift in the work that I've seen, growing up as a consultant in the last few years.
Do you see, when you say that they're only targeted biopsies, do you mean they're a template biopsy with a target or solely targets?
So solely targets or a maximum one other site of random sampling. I mean, it's beautiful in terms of the workload per case, but the number of cases I've told you is, this is the first time in 7 years we're fully staffed. So 600, 700 biopsies coming through is a lot of work.
I think it's, again, I should emphasize, UCL, University College London, they have got their radiologists, they're supposed to have one of they are the forefront of prostate multiparametric MRI.
Of us, 9 uroradiologists catering to just prostate cancer.
Right. So they have got a very specific. So they've got so they trust their radiology a lot more than many other centers would. Okay. I think it's been a very good session. I think we could go on for another hour, I suspect, very easily, right? Especially if you leave it to me to keep chatting. But I think we will stop here for interest of time, because I'm sure all of you have got a real life to live. And unlike us, it's not late in the evening. And Yoon, it must be pretty late for you by now, I think, in Singapore. Yeah, I can imagine. Good night.
Oh my goodness.
So I think we definitely need to, I was going to say we need to call it a day, but I probably should say we need to call it a night.
Night.
Okay. Bye all. Very nice. Thank you very much for a very good discussion.
Thank you,
Thank
Murli.
you.
Thank you.
Thank you.
Thank
Bye.
you,
Bye.
Murali. Bye. Thanks, everyone.
For the invite.
Bye.